you.
Just want to thank you once again, Lesego, for helping me just to get all of this organized and for bringing me onto the platform and welcoming me on. I really appreciate the collaboration. I'm a member of this platform myself, colleagues, and if I don't have a church commitment on, then I'm always on the trainings with you guys, and I'm ever so grateful to catch up when I've missed on those micro lessons. So one of the things that we felt we would do in rounding off the series as we talk about pre-exposure prophylaxis. And today we're going to be discussing Lenacapavir. We're going to do things a little bit differently this day. For those of you who may not be familiar with what pre-exposure prophylaxis is, I've just put this slide in just to give you a brief background, right? So what's the difference between PrEP, which is pre-exposure prophylaxis, PEP, post-exposure, and then ART. Most of you are familiar with ART, so I won't do those. But PrEP is where we take a medication prior to exposure to an infection that we actually want to prevent. So in the case of HIV, an HIV negative person takes antiretroviral drugs to prevent them becoming infected. So in South Africa, we have registered products already. So we've got oral PrEP, which is TDF and FTC. We've got the dapivirine ring, which we spoke about last time, and cabotegravir long-acting. And oral PrEP at the moment, these are SAPRA approved, so they're registered in our country. And oral PrEP, however, is the only one that's available within our local facilities. And then we have post-exposure prophylaxis, which is what we should have access to even at a PHC site. It's not just for sexual assault victims. It's for anybody who's had an exposure to possibly to HIV and who comes within 72 hours. And we give them 3 drugs over the course of 28 days to prevent them becoming infected to HIV. So because we're talking about lenacapavir today, maybe you can launch the first poll. We've got 5 questions that we're going to ask now, and then we'll ask these questions again at the end. So the first question is, which class of ART drugs does lenacapavir belong to? Is it NRTI? Is it NNRTI? Is it integrase strand transfer inhibitors? Is it entry inhibitors? Is it a capsid inhibitor or a protease inhibitor? We're giving you 30 seconds. So we've got a mixed bag. So we've got some that are saying INSTI, some saying protease. I'm not sure. We are up to 190 of 700 people. And you'll stop it, right, Lesego?
Yes, I'm actually showing the results now.
Oh, okay, wonderful. So we can see that we've got a few people, and we've got every single class that's actually been picked here, with the majority of you thinking it's an INSTI, second to a protease inhibitor. Great stuff. Next question. So for lenacapavir, are you aware what is the total dose of lenacapavir that's going to be given subcut, and how many injections would it be to give that dose? So we've got, people are fast today.
I've never seen it moving so fast.
People are fast on the trigger today.
Yeah, okay, I'm
Okay.
gonna stop and then show
All
the
right.
results.
So we've got some of you thinking it's a single 300 milligrams. Some think it's a single 463.5. Some think it's 2 injections. Some think it's 5,000. Great stuff. Let's move to the next question. And so this talks to the maintenance dose schedule of lenacapavir supplement. How often is it given? Is it given every 12 weeks, every 24 weeks, every 26 weeks, every 28 weeks, every 30 weeks?
There we go.
Right. So the majority of you think it's given every 12 weeks. This is followed by every 24 weeks, followed by every 26 weeks. Great. Thank you. Let's move to the next poll. So regarding lenacapavir now, which of these are you on 4? You're on 5 already. Okay, we can go to 5. It's fine. All right. Which of these drugs can be taken with lenacapavir? And there's more than one answer, right? That could be right on this question. Can the poll allow for more than one?
Yes, it's on multi-choice. Yeah.
Okay, so you can choose more than one. So which drugs can we take with lenacapavir? Great. So all of them. So from our audience, I'm sure there's many of you that would have put in multiple answers, but the audience thinks that we can take Len with all of these drugs. Wonderful. Thank you. Thank you so much. I'm going to move on to the next slide now.
Let's go to question 4, Doc, because I think
Okay.
it was my error.
Okay. And this is also, there may be more than one correct answer. So regarding lenacapavir as PrEP, which is or are correct? There were 0 HIV infections in cisgender women receiving twice yearly lenacapavir for HIV prevention. Lenacapavir is registered by the FDA for use as PrEP. Lenacapavir is approved by our SAPRA.
The
Right.
results?
And so our audience, we've got 72% of you that have put lenacapavir is registered by FDA. Basically, we've got people who believe that it may be all 3 of these that are right. So wonderful stuff. Something a little different. I come from a background of using polls in training, so love to do that. So question number 1 was, what class of ART is lenacapavir? So it was developed by Gilead, and it is a capsid inhibitor. It's the first drug in its class. And we're going to talk a lot about how it works in a little bit. For those of you that answered question number 4, it was already proved for use in heavily treated ARV patients in 2022. And it's more recently now been approved by the FDA for use as PrEP. And according to the manufacturer, there's no known cross-resistance yet to other existing ART classes. So I'm going to take a little bit of time just to go into, a little bit of the HIV construct so that we can understand, because I wasn't very, very familiar with it. And so just taking you step by step through it. So you are aware of the HIV structure. We've got the envelope, which has the glycoproteins that are used for attachment. And you see this inner portion here is our HIV capsid, and that's the core that contains our HIV RNA. So when we are talking about capsid inhibitors, so when they talk about capsid inhibitors, they may refer to everything that is within the HIV core, which includes your enzymes, it includes everything that's within that core, including the genetic material, or it may refer to the outer coating, this HIV capsid here, which is coating the P24 antigen that coats the core. If you look down at this diagram at the bottom, the conical HIV capsid, which is what we're really going to be referring to, right? The entire core itself, it's made up of these hexamers and these polymers. And these will become important when we understand how lenacapavir actually works, because it's got a very unique mechanism of action. So just want to take you a little back to help you understand how the core is formed. I last did HIV training. I mean, some of you might have just been been entering matric when that's how old I am, right? So this is the HIV gag. It's a long polyprotein that's actually the precursor for the HIV capsid. So what happens is gag gets cleaved by protease, right? And the protease, these capsid monomers, which are those P24 monomers, these congeal together to either form hexamers primarily, or these pentamers, which when they come together will form this actual core. So when we talk about where Len is targeting in the stages of replication of the HIV life cycle, one of the things which we understand now is that after HIV enters the cytoplasm of the CD4 cell, this core does not disintegrate, right? So the core does not disintegrate. Reverse transcription starts to occur when it enters the cytoplasm. This entire core goes through the nuclear core complex into the CD4 cell, once into the CD4 nucleus. Once it's within the nucleus, this capsid then disassembles. We have integration that happens, and then translation to make your mRNAs. And lastly, at this step, you have your gag, which acts like a spoken wheel, and you get viral assembly again. So Len works at this stage, and this stage of the replication cycle. So how does it do that? So I've shown you this picture before, right? So you've got these capsid monomers which congeal to come together to form subunits, hexamers and pentamers. So lenacapavir is this yellow substance here, which comes and binds to the subunits, and it acts like a door, a hinge on a door, and makes them stick together. So when Len sticks to these subunits, right, as it's coming, so this is your cytoplasm, as this capsid is now coming to enter the nucleus of the cell, these yellow and blue, you see these yellow strings, these blue strings here, are the human proteins that help the capsid squeeze through the nuclear pore. So when Len binds to the capsid around it, so these little dark yellow, these triangles around the yellow are the lenacapavir. When it binds it, it makes this capsid stiff, and it blocks it from binding to this CPSF6 protein. So it interrupts the movement as it's getting transported into the nucleus. Next, what happens is the capsid has to disintegrate. And because it has to disassemble in the nucleus so that integration can occur, this doesn't occur because of the way that Len is bound to these subunits, these hexamers and pentamers, so that downstream integration therefore cannot. So it's not integrase inhibitor. Remember, it's a capsid inhibitor, but the action actually prevents integration as well. The last step actually happens there, where you see the reassembly maturation and binding. So because Len has now attached to the subunits, they become attached too quickly as they're being assembled. They are become misshapen and you don't get a proper capsid being formed. So the core formation is actually disrupted. What you end up with is an HIV virus that is non-infectious and unable to replicate. So that's the mechanism of action of this novel capsid inhibitor. So I'll briefly talk very quickly about the phase 1 studies because there was nothing too dramatic. They did phase 1 studies in healthy HIV negative volunteers, which showed a good safety profile. And then they did a proof of concept in a blinded randomized trial with HIV positive clients who had been virally suppressed on ART for at least 18 months. Their CD4s were more than 500, and they were given the Lenacapavir together with broadly neutralizing antibodies. And in that study, the most common AEs were grade 1 injection site reactions, and there were no side effects. So even in HIV positive individuals, because it's registered, remember, for use in HIV, it had a very, very good safety profile. So when you look at Len's dosing schedule, so if you look at the package insert from the manufacturer, it comes as an injection. Each injection has 463.5 milligrams of lenacapavir. Because it's given into the subcutaneous material, and it's got a slow release from the site, it takes a while for the Len to reach maximum levels. So oral loading doses are needed when we are giving the lenacapavir. So there are 2 ways that you can be initiated onto lenacapavir. The other thing that I just want to say about the oral formulation, it comes as a 300 milligram tablet. It takes about 4 hours for it to reach its maximum levels, and it has a half-life of 10 to 12 days. So in option 1, on the very first day, you would obviously have been screened for HIV, and you would need it to have been HIV negative and not requiring PEP. You would get 2 of these 300 milligram tablets, along with 2 of the 463.5 milligram injections. It comes as a 1.5 mil injection, so you would get 2 of those subcutaneously, meaning you get 927 milligrams of lenacapavir in 2 injections. On day 2, you would then get 600 milligrams of lenacapavir. The other initiation option shows varying doses of the oral formulation taken at day 1, day 2, day 8, and then on day 15, you would get those 2 1.5 mil injections, giving you a total of 927 milligrams. Once you've had that first Len injection, your maintenance injection is every 26 weeks. Remember, there's 52 weeks in a year, so you would get it every 26 weeks from the last injection date. On the package insert, you are given plus or minus 2 weeks when you would be within the window to get those. So this would be important for you to recognize. So when they did the phase 3 studies, they used the initiation 1 option when they were providing lenacapavir. And we're going to talk more about that now. So the first study, the purpose 1, was a double-blinded, randomized, active control trial evaluating the safety and efficacy of twice-yearly subcut Len or daily oral TAF with your usual oral PrEP, emtricitabine, and tenofovir as your active control arm. Right? Because remember, we can't have any placebos because we now have drugs that work. This was in cisgender women aged between 16 and 25. There were 25 sites in South Africa, 3 sites in Uganda. You can see the vast majority of these participants came from South Africa. They needed to have not used PrEP within the last 3 months prior to being screened. and should not have had they should have had their last HIV test more than 3 months after they've been screened. I put a little bit of information in case people are not sure what the FTAF is. So this is emtricitabine and tenofovir alafenamide. This is an NRTI. TAF is a prodrug of tenofovir, and it's converted inside the body into the active drug tenofovir diphosphate. It's a lower dose than the TDF that we used to, so it starts at 15, goes up to the max dose of 25 milligrams, which is from 25 kilos, and it's approved for use with FTC as PrEP in men under the name Descovy. What's great about it is it's got activity and can be used for the treatment of hepatitis B. And compared to tenofovir, it's vastly less nephrotoxic. It's got less bone mineral loss, and it's got less systemic exposure. It's a smaller tablet. It's a lot easier to take. So now we come back to purpose one. So the 3 arms, it's blinded it's a double-blinded trial. So what would happen is you would get 2 days of oral, you would get an injection on your first day, and then every 26 weeks you get another injection, and then they would do an analysis after 50% of participants had completed more than 52 weeks. So if you were in the randomized to the Len arm, in addition to those Len 600 milligram tablets, you would either be randomized to get the placebo for FTAF or for TDF and FTC. If you were randomized to get FTAF, then you would get a placebo of the Len injection. So everybody got an injection, everybody got all the tablets, but if you were in an active arm for something, you would get placebos, right? And so if I was in FTDF, we would also get the placebo. So what they did was, during the screening process, they worked out what the background HIV incidence was in clients that were not on PrEP. Because remember, in order for you to be eligible for screening and enrollment on this program, on this study, you needed to not have been on PrEP within 3 months of the study starting, so that this would have been expected in a placebo group. The primary analysis was to look at how does Len perform against the background HIV incidence that was determined, and how does FTAF perform against the background HIV. And then they compared Len against the active control FTDF and FTAF against the active control FTDF. And so over 8,000 was screened. The first participant was screened in August 2021, and the last one was randomized in September 2023. They were screened with 4th generation HIV positive tests as well as lab tests. And you can see there was some drop off after that initial screening that happened, because some had HIV positive tests, some were pregnant or lactating, and they were not moved on. So in order to move on to randomization, you had to weigh 35 kilograms, because that's a requirement for Lenacapavir, right? As well as for the Lenacapavir, and you could not be pregnant, and your EGFR needed to be above 60. And a little later on, you'll understand that there were specific drugs that you cannot take lenacapavir with, so those would have been excluded. After the randomization, there were those that still fell away, and what we landed up with in the 2:1 ratio was 2,000, just over 2,000 received Len, over 2,000 received FTAF, and over 1,070 received TDF. And so what we are going to talk about now as we're moving forward, because now we have, after the unblinding, we've got the open label phase that's happening, and that's what you are seeing here. So when you looked at how they conducted the study, so we saw you at the baseline enrollment visit. Then you were followed up at week 4. You were seen again at week 8. You were seen again at week 13 and every 13 weeks after that. Everybody had specific STI testing at the baseline visit, and then every 26 weeks after that. And they gave a 7-day window for injections. Remember I said to you when I spoke about the scheduling, if you came within 28 days of 28 weeks, of your last injection, you could continue as you would have. But if you came beyond the 28 days, then you would have to start with the initiation again. The oral, day 1, the oral, day 2, with that injection. Anyone who became pregnant whilst they were on Len were then reconsented to see whether they wanted to continue on Len or not. And so we're going to look now at what the results showed. And this is the first study ever that was groundbreaking news last year that showed that lenacapavir during the study had 0 infections over 1,913 person years, meaning that no cisgender woman got HIV during the study period. For FTAF, there were 39 infections over 1,932 person years with an HIV incidence of 2.02, and FTDF was 16 infections over 949 person years with an incidence rate of 1.69. And so when you look now at the next slide, which is on the y-axis here, you can see we've got Len comparing Len and FTAF against the background HIV incidence, right? So this value here of 1 represents the HIV incidence rate ratio, right? So if I'm less than 1, it means I've got a lower HIV incidence, and this favors PrEP. If I'm sitting here in my performance and I'm more than 1, then that does not favor PrEP. And so when you can see for Len, here's Len. 0, the incidence rate ratio is 0. No infections in the Len group, statistically significant, highly significant with the p-value. And when you look at FTAF was at 0.84, right? So the confidence interval here, 0.5 to 1.28, crosses over the value of 1. And so we cannot effectively say that it shows that it's not statistically significant in difference to the background infection, because this confidence interval is traversing 1. When you look at Len versus TDF, so looking at Len versus that active control arm, the HIV incidence ratio here is 0 with a confidence interval between 0 and 0.10, statistically significant result. When you look here at FTAF, you can see that it's sitting at 1.0, right? So for FTAF, this HIV incidence rate ratio shows that it's more than 1. It suggests that FTAF might be less effective than FTDF, but it's inconclusive because the interval crosses 1. And so FTAF is not proven to be more effective than FTDF. Remember that FTAF has been approved for use in men, right? And so this was one of the studies now that looked at it in the female population. So orientating ourselves to what did they find with regards to adherence, I'll start with the oral preparations. This dark blue is very good adherence. So they took 4 tablets or more in a week, right? This lighter color is they've taken 2 to 3 doses in a week, and the very light one is poor. So what you can see for both FTAF and for TDF, right? The adherence wasn't really good. And this was not verbal reports of adherence. This was documentation from samples. So you can see that 48% of participants were very adherent to FTAF when they first started out, going all the way down to 84% having no to very low adherence. And likewise with FTDF, it was even worse. You can see at 8 weeks, they were at 22%. And by the time it got to 52 weeks, 93% of the people were not, of these participants were not taking their very good dosages in terms of what they should have been taking. When you look at the injections, and what happened with regards to the injections. So this data here is looking at the placebo as well as those who got the active ingredients. So by the time it came to week 26, when they were due for their second injection, 91% of the clients got that injection on time, meaning within that 28-week window. And by the time it got to 1 year, almost 93% of those, when they looked at between the placebo arm and the Len arm, there was similar adherence between the two groups. So what about FTAF? Because I think this was something, a really important question that needed to be asked about its use in women. They didn't speak anything about FTAF and weight here, because I know there are colleagues that are going to ask about TAF and weight, because there has been, compared to TDF, seem to have been that there may have been um, more weight that may have been gained in clients that were on that within ART regimens, but they didn't release any of that data. So we can see, right? So these are the relationship of adherence to FTAF and its effectiveness in preventing HIV infection. So we had case samples that were compared against match controls. So these match controls are the participants who did not get HIV, and we can look, the bars are the same. So dark means that you took your FTAF very well. A light means that you were not taking your FTAF. And so we can see here that in those who acquired HIV, 92% of them had low or no adherence to the FTAF, while only 5% had high adherence and 3%. So 5% were taking 4 or more tablets a week. When we look at those in comparison to the match controls, we can see that in the match controls, 66% only had low adherence, 14% had moderate adherence, with 20% of them having high adherence. So high adherence to TAF was associated with a lower chance of getting HIV infection in this case control analysis. So what about Len safety data? And so if you looked at Len, remember the age groups was 16 to 25. So they looked at data between the 16 to 17-year-olds, and then those that were between 18 and 25. And looking at the relative comparison in terms of frequency of these. So we're expecting injection site reactions, headache because it's a systemic drug, UTIs, all right? And you can see lab abnormalities. When you're comparing those under 18 to those over 18, they're very relatively comparable between the two groups. So even when it would come to market, this is something that SAPRA would be looking at. When you look at injection site reactions, so the most common injection site reactions are nodules. You can see nodules, pain, and swelling. The dark or this teal color means that there's no injection site reaction, right? The yellow means that it's a grade 1. The red means that it's a grade 2. So we can see that even in the phase 3 trials, that we mainly have mostly grade 1 and grade 2 injection site reactions. We can see nodules, pain, and swelling. You can see Obviously, in the active arm, it's a lot more than in the placebo arm, but it did occur in the placebo arm as well. And we can see that as time went on, the frequency of these injection site reactions decrease, right? So the study concluded that there was 0 HIV infections in cisgender women receiving twice yearly Len. Len is superior to both background HIV incidence and FTDF. Len is safe, and TAF was also safe and well tolerated, but adherence was poor, and HIV prevention was strongly associated with TAF adherence. So other studies have subsequently been done. So that was the first landmark that came out, and then later on, we began to get results from Purpose 2. And Purpose 2 is similar study design, very, very similar study design. The only thing is they're not using FTAF. They are looking at Len or TDF-FTC. And in this population, it's cisgender men and gender diverse populations. So it's cisgender gay, bisexual, transgender women, transgender men, gender non-binary persons. 92 sites were where the study was implemented. You can see United States and Brazil had the largest amount of sites. South Africa had 6 sites. We can see in Thailand, because they're looking at those populations where we usually conduct these studies, but Africa was represented here, as well as North and South America, and then the East. So you had to be 16 years of age, and like Purpose 1, no PrEP or HIV test within the past 3 months. Study design, very, very similar. The only thing that's been removed here is the FTAP. So if you were randomized to get subcutaneous Len, you got the 600 milligrams of Len on day 1 and day 2, and you would get the placebo. If you were in the oral active control, you would get a match placebo with it. This is what the data looks like. So they started screening actually before Purpose 1 results were released, right? So they started in June of 2021, and the last person was randomized later in December of 2023. The 4,807 was screened, over 3,800 were randomized, and when it came down to it, you had 1,819 that went on Len and 920 that went on to TDF. The follow-up schedule that I spoke to you about for Purpose 1, week 4, week 8, week 13, then every 13 weeks applies also for Purpose 2. So what did we find? So let's look firstly at this bar graph. So this shows the incidence in the 3 different groups. So this is the background incidence, which they calculated from that screening population, which was 2.37 infections per 100 person years in 4,634 participants. Then we're looking at the number of infections and the incident rate. So in the Lenacapavir arm, right, there were only 2 infections that occurred in 1,938 person years, right, which is really significant. When you look at FTDF, FTDF had an incidence rate of 0.93. There were 9 infections per 967 person years. When you look at what this equates to in a median follow-up of 39 weeks, in the where 2 infections occurred in Len reduced HIV infections by 96% against the background, and I'm going to show you that now, and by 89% versus oral TDF-FTC. So here is looking at how does Len's incidence rate ratio compare to the background incidence rate. Remember, that will be here at 1. And you can see that the incidence rate ratio for Len is sitting here at 0.04, right? When you look at the incidence rate compared to TDF, you can see it's sitting here at 0.11, which shows that it's 96% reduction in HIV infections and 89% reduction in HIV infections compared to TDF. How did this group in that were taking the oral drugs work out? You can see, right? Remember, in the FTAF group, the highest we ever saw was 48% at week 8, and by the time it got to week 52, they were almost at 80 something percent that were not adherent. But you can see that in this patient population, they really had much higher adherence to the FTDF as compared to that female cohort that we saw, where they started at just over 20 something percent here at week 8, and they got down to less than 5% in week 52. Safety data, when you're looking at the safety data for LEN versus TDF, and you're looking at rates, you can see similar, any AEs, similar across both. Grades of infection, similar across both. Was there, for those where it was in more than 5%, remember this is a group that involves men who also have sex with men, so they had a lot of rectal chlamydia, oropharyngeal gonococci, upper respiratory tract infections, diarrheas, headaches, influenza. So you can see very comparable between the two groups. There were 6 deaths across the study. None of them were related to the study product at all. When you looked at injection site reactions, right? Similar manifestations to Purpose 1, 63.4% in the LEN group versus 39.2% in the FTDF. They also had pain and erythema, but mainly grade 1 and grade 2. So whereas in Purpose 1, only 4 participants stopped their injections, here we had 29 participants that discontinued due to injection site reactions. It was 26 in the LEN arm and 3 that were on placebo in the TDF FTC arm. And as we saw in Purpose 1, with every subcutaneous injection, these injection site reactions decreased. So what was the conclusions? That this twice yearly LEN is effective in populations that include cisgender men and gender diverse populations, right? Who are having sex with a partner assigned male at birth. LEN is associated with a 96% reduction in HIV against background HIV incidence, and compared to the incidence in TDF FTC, 89%. AEs were not really an issue between the two arms, and they're now in an open label phase where they are now getting it as per the schedule that we've shown you, and then there will be a PK tail phase when that's done. Sorry, my slides are jumping. There are other studies that they are doing, which is Purpose 3 in the US, where they're looking at cisgender women in the US, and that's going to run until January 2025. We've got Purpose 4, where they're looking specifically at people who inject drugs. And I'll speak to you a little bit more about that, because remember, people who inject drugs may be on methadone and these other opioids, right? And that's scheduled to run until July 2027. And then we have Purpose 5, which is looking at this gender diverse population, but in France and the UK, and that's going to run until 2029. So just last month, LEN was approved for PrEP in the US. The approvals have been sent to the European Medicine Agency, South Africa, and Brazil. So we are waiting to see what will happen with these different regulatory approvals. Remember, in South Africa, it's first the RCTs are done, then it gets approved by an authority on medicine regulations before SAHPRA will do it. So in the case of the ring, remember, it was approved by the European Medicines Agency. The FDA has approved it here. SAPRA would not really need to wait for EMA if they needed to approve this drug. I've told you this before. I'm just reiterating the point. The oral formulation is a 300 milligram tablet. You must weigh 35 kilograms. It's 2 injections, 1.5 mils each subcutaneously. It can be given at 3 and 6 monthly intervals, but for PrEP, it was given and proven to be effective at 6 monthly intervals. And the dose is then 927 milligrams subcut. It takes time for the subcut to reach the peak values, so the oral loading dose is needed. And when we eventually roll in out, all countries are going to have to understand how they will do this programmatically. So the package insert comes with 2 vials, it comes with 2 syringes, 2 withdrawal needles, and 2 injection needles, because remember, you're going to give 2 injections. And then it just gives you really nice instructions of how to give the injection. Preferably, it's only given in the abdomen, so you'd want to give it 90 degrees is preferred, or up to 45 degrees is acceptable. And then you'd need to be at least 2 inches away from the first injection site when you're giving the second injection into the abdomen. So this is something that's also very interesting, and what we are seeing with these newer agents, right, that there are drug interactions that we will need to be taking note of. So the great news is you can give it with antacids, oral contraceptives, and sex-affirming hormones, but strong inducers of the CYP3A-YP and the GPUGT1A like rifampicin reduce lenacapavir's concentration. And so there are drugs that are contraindicated with it. It's interesting to note that when you read the package insert, lenacapavir also increases the doses of some statins, tramadol, fentanyl, the PDE5 inhibitors, midazolam, triazolone, opioid antagonists, ERBA derivatives. And on the package inside, it states that the interaction with methadone is not known. And so that's why they're also doing these studies with people who are injecting drugs to understand a lot of those questions. So if you're looking at the interactions, anticonvulsants, the usual suspects, right? Absolute contraindication with carbamazepine and phenytoin. It's not recommended with phenobarb or with oxcarbazepine. We should use alternative anticonvulsants. And you saw the similar story when it came to Cabernet. Interestingly enough, atazanavir, cobicistat, and atazanavir ritonavir increases the concentrations, and its recommendation with lead is not recommended at the moment. When you look at our NRTIs, efavirenz and navarapine, and then the other PI, tipranavir, ritonavir, these decrease the concentration, so using with len is not recommended. The rifamycins, rifapentine, rifabutine, rifampicin, contraindicated with RIF, not recommended. And then St. John's wort, which we note it's also contraindicated. I think the big issue is going to be this. It's going to be the cost. So it currently costs more than $42,000 a year in the USA. So in South Africa, there's like 370,000 Rand for 2 injections. Apparently, it's relatively simple to make, but apparently this pharmaceutical ingredient is complicated and expensive to make. But hopefully, according to this article that was in the Journal of Antimicrobial Chemotherapy, if it could be mass produced, because it's currently exported from India on a 1 kg scale, right? So if it could be mass produced and we have generics that are coming in, it could go down to $99 per person per year for 1 million users, and even lower to $41 for 10 million treatment years. And I think this is going to be the big game changer. I think that the cost, especially when they're looking at injectables, our health economists are going to look at comparing CAB and LEN, which is going to be, if these prices come down, Hopefully, generics might be in production by 2027. But there's a lot of activism going on there because it's not yet even been used in market. And so we're not quite sure what's going to happen. There's also a once yearly injection that's also under study. All right. And this was a phase 1 study done in HIV negative volunteers where they gave them 20 got a 5% ethanol, 5,000 milligram dose in the arm, and the other 20 got 5,000, 10%. And they were looking primarily at concentrations and safety. And so the injection site pain was mild to moderate. It was the most common in 80% in the 5%, 75% in the 10% formulation. These resolved within a week. Plasma concentrations stayed above 95% efficacy for at least 56 weeks. And so they concluded that the pharmacokinetics were adequate for once yearly dosing and IM administration. So watch that space. So coming back to the poll that we did before, we can launch it. Question number 1. Which class of ART drug does Lenacapavir belong to? Oh, I'm liking what I'm seeing.
We'll just give these ones 20 seconds, I think. Okay.
Yes, yes.
I'm going to stop this one and then show you the results, colleagues. So these webinars do work, contrary to popular belief.
So great. So whereas in the beginning, most of you thought it was an INSTI, 83% of you have now gotten it right. It's a capsid inhibitor. We'll move to the next one. Oh, sorry, I went to the wrong slide. Ah, something is wrong here.
Click anywhere with your mouse cursor on your slide. With your mouse, just click on the slide. Let's see if it moves. It's not
But
moving.
now I'm seeing it showing the answer.
Oh, let me run the polls without you moving. So maybe you can go back to your first one. And then I will run them, then you just show them the answer. Let me run the second one. You can read on the
All
poll
right.
when
So the
I
lenacapavir maintenance dose is given how often? Every 12 weeks?
oh,
Oh, the single injection. Oh, is this number 2? Sorry, something's happened with my slides. I don't know what's happening. All right. So
yeah,
what is the total dose that we give?
yes.
Oh, I like what I'm seeing.
The total dose. Okay, yeah, okay, there we go.
The
Sorry about
total
that.
dose of lenacapavir subcut. What is the total dose and how many injections? Is it
Yeah.
300?
Okay.
Well done, colleagues.
I'm going
Well
to
done,
stop
colleagues.
and then show the results. There we go. There are some outliers.
Yeah, there are some outliers. So let's just help the three. Let's just help the
Yeah.
outliers. So the 300 milligrams is the oral tablet, right? So that's a
Yeah.
300 milligram tablet. And
Yeah.
in order to get lenacapavir, you get 2 injections that come in the pack. Each injection has 463.5 milligrams. So with 2 injections, you're actually getting a dose of 927 milligrams. Thanks, Lesego. Please run the next one because I'm showing the
Okay.
answer on my side.
Okay. Cool. Let me relaunch. We are on number 3, I hope. The one that starts with Lenacapavir
Yes,
maintenance.
yes,
Right.
the maintenance dose. Ah, I was, you know, when you do training, Lesego, and you see
Yeah.
100%, you get excited there.
Yeah, you must, because
So,
I mean, okay,
right.
I'm
So
going to show I do.
how frequently do we have to take lenacapavir? For those of you that are answering and you have said 26 weeks, you are
Yeah,
correct. So wonderful. The vast majority of you have now gotten it correct. They give leeway for up to 26 weeks, but it should be given every 26 weeks. Thank
yeah.
you. Well
I'm
done,
really
colleagues. I hope we've
yeah.
learned something.
Okay.
And then regarding lenacapavir um, as
As
PrEP,
prep.
which is correct? Uh, which of
Yeah,
these answers are correct?
yeah. Remember, colleagues, more than one can be correct. More than one.
As long as you don't put the incorrect one, because there is an
Yeah.
incorrect one. Hint, hint.
All right. There's the response. Awesome.
All right. So the first two statements here are correct. Len is not yet approved by our
On
SAPRA.
Safra. Mm.
So in the study so far, and we'll see from the open label whether it remains at zero infections, but there were zero infections in cisgender women who received the twice yearly Len, and it's registered as PrEP. Thank
Awesome.
you.
The
Thank you,
last one.
wonderful colleagues. Last question. Yo, this one might be a bit much, ne?
Yeah,
Which
but
of these drugs can we? It means that there's no interactions we are worried about with lenacapavir. That means we can take it. It's
mm,
not contraindicated.
I see a horse race at the bottom there. Okay, I've just showed the
Right,
responses. Yeah.
right. So from 5 to 7 are the answers. If you put 5 to 7, those are the drugs that we can take with lenacapavir. So we don't have to worry like we do with dolutegravir, né? For the oral dolutegravir. We can take antacids, we can take gender affirming hormones, we can take contraceptives. All of those others are contraindicated with it. So in conclusion, colleagues, we've learned tonight that lenacapavir is a novel capsid inhibitor registered for PrEP by the FDA from 35 kilos of weight. Initiation is at a dose of 927 milligrams subcut into the abdomen in 2 injections with 600 milligrams of oral Len for 2 days. And then the maintenance dose is 927 milligrams subcut every 26 weeks. It was superior to background HIV incidence and FTDF with zero infections in the Len arm in cisgender women, and it had a 96% reduction in HIV infection versus background HIV in cisgender men and gender diverse populations, with an 89% reduction versus the incidence with FTC TDF. And if you look at that lower value, that was the same value that CAB had in terms of efficacy in females, right? Highly effective. Len is safe. It was well tolerated. There are a few injection site reactions which we'll have to worry about. We don't have to worry about oral contraception and gender affirming hormones, but when it comes to the inducers, these are something that we will need to be worried about. And so these are one of those where we're probably going to be sitting with Liverpool HIV drug interactions checker when we are seeing anybody. Other great news about it is that it can be used in clients with renal impairment. So let me end the show. That is my last slide. Thank you very much.
Thank you. Thank you so much, Dr. Rochelle. Another awesome one. I mean, I'm fully, personally empowered, and thanks to you, now I can go and talk about it properly.
Yeah, this is the
Properly.
only study. I mean, I've been involved in oral PrEP like as
Yeah.
in the trials. I've been involved
Yeah.
in ring, and I've been involved in cab. This is the only one that I was not physically involved in, but it's
Yeah.
certainly very, very exciting. Very, very exciting.
Awesome. Awesome. No, thank you. Thank you. I really, really appreciate this. I know, people sometimes, they see you teaching, but the preparation takes a lot of time. So we should never get to a point where we take it, for granted when people come and present awesome this thing. I have like 9 questions of my own, Rochelle, but I'll
Sure.
slot them in between. Maybe just to break the ice, is there a place for self-administration? I don't know in these studies who was administering
So in the
the
studies,
injectables.
it was not self-administered. It's
Yeah.
not like the DMPA subcut that's going to be coming out. It was provider administrated, but I think because it is a subcut, and because we've now seen DMPA that's been launched as a subcut, I think that that's probably going to be the next step.
Awesome. Awesome.
That's probably
Eh,
going to be the next step.
yeah, David Elia says the older guys would love the upregulation of your PDE5 inhibitors. What's it? A positive benefit there compared to the other preps. I think I will choose this one. I'm heading for 50.
Ah, yeah, and the thing is that what they're always saying is that you've got to use it and watch dosages of the other drugs that you're on. And so when it comes
Yeah.
onto market, because when we do these studies, all of these populations are really not included because you're trying to be as diverse as possible.
Mm.
And but you like you can see pregnant women were not included in the get-go, but if you became pregnant, you were given the option to stay on it. And we're probably going to see more of the pregnancy data that are coming through in time. I know that there were at least 193 pregnancies on the Len arm in the study, and they have outcomes for about half of those. They had a lot of the pregnancies that were either spontaneous miscarriages or induced abortions, and those
Mm.
the relative frequency of those was in same as relation with the background population that we can expect. So it's too few pregnancies at the moment to know anything. There wasn't any difference in terms of pregnancy A is in the different arms, whether it was LEN or TAF, FTAF or FTDF. We know that there was one baby born with a polydactyly in the LEN arm, one baby, of, but when they looked at the family history, that family history had a very strong family history of polydactyly. And so that wasn't something that was of great concern but we're waiting to see more of the pregnancy data. Okay, all right. So in South Africa, I'll just answer the question that you're showing, right? So that was on my first slide. So of the 4 PrEP options that we've now spoken about, oral, ring, and CAB are approved by SAPRA.
Mm.
Len is approved by FDA. It's been submitted to SAPRA for approval. Once it's submitted to SAPRA, remember that it then needs to go to NEMLAC. And NEMLAC has to make a determination about whether it will be available within our essential medicines list. So at the moment, Ring and PAB are not available through NEMLAC, and a large issue is the cost. The studies which we were doing as the implementation science, they wanted more data, especially with the Ring around young adolescents, and they wanted data of use in pregnancy. because the ring is contraindicated by SAPRA in pregnant and breastfeeding women. And there's a lot of data that's now coming out from implementation science related to that. But cost is probably going to be the biggest issue about whether we're going to see these drugs. The cost, remember, needs to come down quite significantly.
Awesome, awesome. So Paolo has a question about STIs, but I would love you to respond to it because I had a question which usually comes up in our program meetings. I'm sure you know my well, the where we have these meetings with DOH. When there was a spike in STIs and how they published their results, I was the advisor there last year, and PrEP was blamed to say STIs are going up because there's a increase in the use of PrEP. And even in the condom space, they say condoms are low because, I don't know, people were fearful of HIV. What's your experience, your own practical experience, but in the studies as well, this one and other studies, is the relationship between increased use of PrEP and the transmission of STIs, other STIs other than HIV? Yeah.
So if you looked at the Purpose One study, and maybe when you looked at the Purpose One study and you looked at the female, so with us in the public sector, we don't do diagnostic testing, but in these trials, they do diagnostic testing. So whether you have an STI symptom or not, they were testing for chlamydia, they were testing for gonorrhea, they were testing for trich in the females, they were testing for syphilis. They found an astonishingly high percentage of females at baseline had STIs. Up to 25% of those females had chlamydia. They were a little less, they had gonorrhea, even syphilis, right? And so with syphilis and all of these infections, remember the population that we serve are sexually active. The population that we serve are already not using condoms. Hence, the need for them to have an additional HIV prevention method. So what we know is that in this population, even when you look at in the male study, in the cisgender study in Purpose 2, their HIV incidence rate, there's STI incidence rate, the prevalence at baseline was slightly less than women. We always encourage condom usage, and we encourage multiple methods of prevention alongside our PrEP methods, because PrEP is always used in a combination. What we find, though, is that people may or may not be using condoms for various reasons, or they may not be able to negotiate condom use. So, for example, in the patient population that we had in our CAB study, it was a sex worker population. And a lot of their clients were asking for, you get paid more if you don't use a condom. And so PrEP becomes essential for them. I think one of the evidence that we can see from the studies is that they don't report less condom use within the studies when they are utilizing PrEP. And I think that speaks to how we talk to our clients about how these drugs work. Because I think also, especially if you are in the auto PrEP space and you are talking to an adolescent girl and a young woman, right? Remember that condoms are not also 100% effective against preventing STIs. And so we know that we have a higher risk with Neisseria and chlamydia and our ulcers, etc. But viral shedding happens in some of these, even the shedding happens even when there isn't anything present. And so a condom may be up to 50% protective in some of these STIs, which is why we always encourage them to use it. And so our experience within our PrEP program, unfortunately, we were in a community-based program. Our follow-up rates were not as good as you would see in some of these studies, but we did not see that many STIs. We did not, especially amongst AGYW. We saw more at our first initiation visit than at our follow-up visits.
Awesome, awesome, awesome. I will invite you to those meetings so that you can help me with the with the response. So, Wilfred, I don't know. We're saying other contraceptives contraindicate. I think that the
No,
audience
no,
may
you
have
don't have an issue. You don't
misinterpreted.
have an, yeah, we worry
Yeah.
mainly about the oral, right? Because that's the one
Mm.
that's gonna undergo most first pass if it's going to. And so we don't have any worries with our contraceptives.
Awesome, awesome. And then I have a question for you. Any issues with half-life after stopping and maybe cross resistance? I know it's a capsid
See,
stuff.
yeah,
Yeah, yeah.
so if we look at the ART studies, we know that there are mutations that are specific to capsid. I
Mhm.
think because there haven't been, I mean, we've got two phase 3 studies now where we've only got two infections
Yeah,
out
yeah.
of out of over 3,000 people. And so it's
Mhm.
still very early days to
Mhm.
talk about that. That's why you can see in the open label, like they did for CAB, in the open label extension, they are looking to see about covering that tail,
Mhm.
right?
Okay,
Because
okay.
it is quite a while. And we're going to get the data to know what it is. We don't know it yet, because
Mhm.
remember, they're still in the open label phase.
Yeah, sorry, Rochelle, talking about those two cases, whether is there unique context under which those infections occurred?
Oh,
Is there
sorry.
something, was there
Let
any?
me just go back. Did I not share that slide? Apologies. Ah,
No, you,
can I
yes, because I wanted to get whether there were drug-drug
let me
interactions or it was an obvious infection without any confounding factors in the science space.
so so this was what is shared in the paper. I've not seen much more of this in the public space, right? So
Okay.
there were these two infections that they had. So participant A, which is the one in green, and participant B, which is the one in purple. Participant A was a transgender woman who had been diagnosed with latent syphilis and treated at baseline, right? And then she was known to engage in transactional sex and was diagnosed with HIV here at week 13. Participant
Mhm.
B was a cisgender gay man diagnosed and treated for rectal chlamydia uh, um, at the screening visit, and then was then diagnosed here at week 26. One of the things when you're looking at the concentrations of lead, in the paper, they don't give any more specifics, but to say that the doses, the concentrations of these participants were within the range of the overall Lenacapavir concentrations for the pharmacokinetic cohort. What it says was that they didn't have any symptoms of they had not reported any symptoms of seroconversion. When they went and did retrospective RNA viral loads. They found that for participant who was diagnosed at week 13, this one in green, they found a detectable viral load at week 8, and for the participant that was diagnosed at week 26, that what they noticed was there wasn't any delayed like we saw with CAB, they didn't seem to feel there was delayed um, detection of HIV. So they didn't have it at baseline. They didn't find it at week 4. The first one for the first
Mhm.
participant, they found at week 8. And they didn't share like specific client
Colleagues, I hope you can
characteristics.
hear Rochelle because
Can you
maybe it's
hear
just
me?
yeah, you are back now. I thought it was me
Okay.
only. Yeah, okay, I was just checking. Okay, yeah, thanks, Rochelle. I think
Yeah.
that was quite clear. Um, can you hear me, Rochelle?
Yes, I can hear you very clearly.
Oh, okay, okay. Yeah. So Tapelo so was asking what's the overall comment in terms of use by heterosexuals, and if TLD can reach equals to U with proper adherence, can Len be incorporated on future ART regimens? So maybe the second question is more relevant. Yeah.
Okay,
Len
so
for treatment.
Lenacapavir was approved for treatment in 2022 in heavily treated ART, heavily treated HIV individuals, and they did many studies where they had been failing, and then they added Len on an optimized back. So certainly, one of the things that we remember when I spoke to you the last time, when we talk about the use of these ARVs, especially as we are getting to a place now where we've got TLD as first regimen, second regimen, third regimen, they would be almost really skeptical to want to compromise a drug that may be salvage regimen, right? Because we do still need a salvage regimen. And so in the US, they would be using it as salvage regimen. You're not going to find this on your first line. You're going to find it in highly experienced ART individuals who've been failing, but they must have an optimized backbone. And yes, it can be used in heterosexual remember, cisgender women had male partners. So the cisgender woman had male partners. So it's for use in heterosexual.
Awesome, awesome. This is a common question to say when someone is started on LAN, when can they start to have unprotected sex and feel safe? After how
So
many days,
when you
weeks?
look
Yeah.
at it's that kind of discussion is not really given very clearly. But if you look at the oral Len, right? The oral Len, the 600 milligrams, it takes 4 hours to be effective at
Oh.
maximum levels, right? It takes
Mm.
4 hours to reach its T max, and then it has a half-life of 10 to 12 days. So you take
Okay.
dose number 1 and dose number 2. I think that one of the things that I think NDOH will likely be looking at is this is the kind of clear guidance that will come through when we write in the guidelines to say, what is it now we are going to say you can from day 2 after you've reached your T max, because what we wouldn't want is for people to say tonight's the night and and
Tonight's
so
the
this is
night, colleagues.
tonight's the night we take Len and we use it like they are
Yeah.
using PrEP, the 2-to-1. So these are the practical questions that we would be, because people also don't know how they will react when they're going to take these medications. And so I think that's a lot what we want to see. The good news is it's been studied in South Africa.
Yeah.
It's been
Yeah.
studied in our
If
population. And so
I tell you what, if I participate in that meeting, I'll tell them to just say 7 days, not for any,
let's
just one period for all. Because you can imagine as a health worker now, you have to think this one is 2 days, this one is immediate, this one no. Just say as a general
programmatically
communication. Yeah.
programmatically I think one of the things we are also going to have to figure out if this does
Yeah.
come is our timing with the other PrEP methods and understanding. We're going to see you at 26, because remember we work on 4-week schedules,
Yeah.
and so the second injection's at 26 weeks, and so we'll have to be figuring those kinds of programmatic things out.
Awesome. Okay, there's a question trending linked to that question. People need a little bit of clarity on the actual dosing. You did mention it in your presentation. Can you clarify what happens day 0, day 1, and so on,
Okay.
just on that
So
space?
so
Yeah.
today is the day that you come and we're starting you on Len. So remember, there's 2 different initiation regimens. Most people are preferring, and that's on the ART side that they use that as well. For these studies, they use the option 1. I get 2 tablets of 300 milligrams oral Len, and I get 2 injections on today. This would be my day one, right? So I get 2 oral Len, I get 2 injections of Len, which will total 927 milligrams. Then I will go home with 2 tablets of oral Len to take tomorrow. Then in the study, they saw them again at 4 weeks. They saw them again at 8 weeks. They saw them again at 13 weeks. Then they saw them again at 26 weeks. But after I take my tablets today and my tablets tomorrow, and I have my injection today, my next prep is only week 26 when I'm coming just for injections. No more oral. The only time I
Awesome.
will take oral again is if I've not come back within 28 weeks of my injection. Then I've got to start that initiation again.
Awesome, awesome, awesome. To colleagues, we have run out of time. I wish we do have. I think I'm gonna do is I've been having this idea of this lunch and learn thing, where maybe we bring Rochelle and maybe we have a lunchtime discussion on these topics. Unfortunately, we are like few seconds to 8 o'clock. Maybe Rochelle, as you say, your take-home message. There's a lot of questions here around choice, choice. So if Len was here, Dapi Ring was here, Cab LA was here, what would you choose? But also just stress the issue, the importance of patients, clients, communities having choice. I think this is so powerful. Yeah, but maybe as you sum up your way forward, you can just close on that note. Yeah.
Right. And I think that hopefully we do get choice within South Africa. Looking at where the funding mechanisms are sitting at the moment. We know that everybody seems to be leaning towards these new and novel capsid inhibitors, simply because from a programmatic perspective, and for people, you saw, right? With oral preparations, adherence is very, very important. When
Mm,
people get injections or something that doesn't require me to have to adhere every day, but just remember to come for my injection, we see that the efficacy is really very, very good. For Lenacapavir, there have been 0 infections. We're waiting for the open label to give us more data in cisgender women, and 2 in cisgender men and transgender people. I
mm,
think that activists are really important to get the price of these drugs down. We cannot keep testing these products in Africa and then Africa doesn't have access. And what you think your clients may choose may not be what they actually choose.
mm,
Because contrary to what I thought, even in the face of CAP, we still had clients who really liked the ring and they were scared of injections. And so choice gives somebody the option to say, I'm happy on my oral prep. I don't have issues on my oral prep.
mm,
I'm comfortable with it, versus somebody who says, I'm struggling to take oral prep. I need something that is gonna be longer term and I don't have to worry. I've got issues with my partner. I'm worried my partner will see my prevention that I'm using. And so
mm.
advocacy, 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 and we surely hope we're going to see it soon.
Awesome, awesome. Rochelle, I can't wait for the for the next topic. Just to say thank you again for such an awesome, informative, empowering, evidence-based presentation. Colleagues, that's it for the night. The Diploma Child Health colleagues, let's switch over. We are discussing asthma, allergy, and anaphylaxis in children. It's going to be awesome with Prof. Risenga. Prof. Risenga, Rochelle, became a pediatrician in 1981. That's when I was born.
Wow.
So it's been, it's been a
I
40-year
was
journey.
7. I was 7.
So just listening to him, there's wealth of wisdom, and I'm so happy that on the other side we are hosting him. Yeah, it's awesome in this world of professional development. Yeah, thank you, colleagues. Night, night to
Thank
everyone.
you.
Bye.
Thank you, guys.
Record.